I'll go deeper into my favorite population. So I'm a transplant infectious disease physician. And so what we try to do is we optimize transplantation for our transplant patients and try to vaccinate them 4 weeks before transplant. Okay. The live vaccine cannot be given after the transplant. So I have this golden opportunity before transplant I need to take advantage of to build their antibodies. And so we try to get all the vaccines in their early post-transplant visits, pre-transplant visits, just to maximize filling the tank with antibodies. Because what happens when we transplant them is we give them big medications that shut down both the B cells and the T cells. So when the B cells are not working, they're not giving me antibodies. Okay. So the main ones we focus on are influenza, pneumococcal, Hep B, and herpes zoster. But here in Saudi Arabia, we are focusing on other vaccines as well, including the pneumococcal, meningococcal, because we do know our patients want to go for Hajj and Umrah. And we are doing focusing more on the human papillomavirus because we are seeing a lot of our transplant patients end up with preventable malignancies and skin warts and skin lesions. So again, after collaboration and discussion with our dermatologists, they were really encouraging of us pushing that in our transplant patients. So this is what we do at our center, and we're still working on finalizing our protocol as resources become available. So we try to get the mumps, measles, rubella into them. We give the PCV13 with a plan to give the PPSV23 in the next visit. The Tdap is given to them upfront. COVID-19, especially if it's winter, and we check the titers for Hep A, B, varicella, and MMR. The hepatitis A and B are given during the second visit, the MMR if they're not immune, and the varicella vaccine if they've not had varicella vaccine before, or the herpes zoster vaccine if they're antibody positive. They get the meningococcal, the Tdap, and RSV vaccine. Post-transplant, now some data says we can give the influenza vaccine as early as 1 month post-transplant if it's the winter season. And so again, based on the patient and the kind of transplant, we are encouraging it. Again, we don't know if it's going to be protective per se, but we know we've tried our best. And RSV vaccine if the patient is above 60 years old. Now let's assume the patient got 1 dose of zoster vaccine and not the second. We go ahead and give the second 6 months post-transplant. Let's talk about another special population, which you may or may not encounter, which is patients on biologics or immunosuppressive therapies. So again, what we try to do is we optimize all their vaccines before therapy, and we try to make sure that we fill the tank. Because after the therapy is started, we only give inactivated vaccines. And the inactivated vaccines, again, the body may not have the ability to mount the response based on the biologic they're receiving. So again, we try to fill the tank with antibodies, boost them up and before we hit them with a biologic. Only because the morbidity and mortality from these vaccine preventable diseases is high and is preventable. With rituximab, we do encourage delaying vaccinations for more than 6 months if the patient receives rituximab. Here is something I got from a UK-based website, and I love the form they use. So what they do prior to starting any biologic, they screen the patients for TB. They do hepatitis screening, medication screening, and then they have a vaccination checklist. So they make sure all the patients are updated based on the routine immunizations. They get the pneumococcal vaccine, the influenza vaccine, shingles vaccine, or chickenpox. So again, they're optimized prior to transplant, prior to starting any biologics. And again, our clinicians are great at doing that and making sure that they optimize the patient as much as they can, especially when they have the luxury of time. Okay, eculizumab is something that always comes in the board exam questions. For those of you who are done with boards, you may see it in real life. So again, the association between eculizumab and serious meningococcal infections is well established. So again, you need to get your meningococcal vaccines in your patients prior to eculizumab use, including the serogroups A, C, Y, W135, and MenB. And vaccination should begin at least 2 weeks before initiating eculizumab. So the idea of the 2 weeks is you want to give the body a chance to mount the immune response and build the antibody stores. Rituximab is another common one we see used in clinical practice. All the live vaccines should be given 4 weeks prior. The inactivated vaccines, we prefer 4 weeks, but minimum 2 weeks for them to be able to mount a response. And what do we give them? The pneumococcal vaccines, influenza vaccines, and the Hep B series. Okay. In addition, all the household members of patients on rituximab should receive all age-appropriate vaccines. And why we do this is we call it the halo of protection, دائرة الحماية. So even if the patient cannot get the vaccine and mount the antibody response, the family members will not bring something from outside to inside, and so that becomes an additional layer of protection. And now we're going to talk about a few recent updates or future directions. The pneumococcal vaccine, now in the Saudi market, we have the PCV20. I'm very excited to see it in all the hospitals soon, inshallah. It takes away the two-step process of the PCV13 and the 23. So it's one vaccine to be given to our patients. And so that way you buy, you don't have to bring them again and makes life easier. So again, if I have to bring this to clinical practice, when my patient gets discharged from the hospital, they get the vaccine وهم طالعين برا. Okay? Same with the clinic. As soon as I see a patient in the clinic, on my problem list, I add immunizations, I discuss it, I force myself to bring it up. It takes a few more minutes, but again, I'm trying to, establish it as part of a practice. The RSV vaccine is relatively new in Saudi Arabia. We're excited to have it. And again, I encourage you to work closely with your lung doctors, your pulmonologists, because their patients are most fragile, most vulnerable, as well as our elderly patients who can benefit from the protection. Because again, keep in mind, our communities, our children are close to our elders. So the children go to daycare, they go to schools, they share all the bugs with their friends and colleagues, and then they bring them back home to the grandparents who are fragile. So again, vaccine preventable, especially in somebody who has lung disease, underlying lung disease, that's the most vulnerable population. I do encourage it for everybody else as well. And with that, I will conclude.
Thank you, Doctora, for this nice presentation. Dr. Afrah, now you give us a great insight and very practical presentation, and you highlighted a critical message that adults, especially high-risk group, carry a significant burden of vaccine-preventable diseases, remain under vaccinated. Your talk reinforced the importance of proactively identifying this population and integrating immunization into routine clinical practice. And this is truly where prevention make the greatest impact. Now we will shift to a very important and often under-recognized condition, shingles, a condition that reflect both aging immunity and missed prevention opportunities. Dr. Dafallah Muhammad. Dr. Dafallah Muhammad is a consultant of preventive medicine and public health physician at the Riyadh Second Health Cluster, Ministry of Health. Dr. Dafallah will talk about shingles unmasking a silent threat in older population or the adult population. Dr. Dafallah, the floor is yours. Please start your presentation.
السلام عليكم ورحمة الله وبركاته جميعا. First, I would like to thank Dr. Raja for the nice introduction. And also, I would like to thank my colleagues in the panel. And also, I would like to acknowledge the organizer for giving me this chance to participate in the, the International Immunization Week webinar. And also, my thanks goes to all our attendees and all our colleagues that are attending this session. In my presentation, I'm going, as Dr. Raja mentioned, I will go in depth, in the area of the shingles vaccination, and also before to explore the RZV vaccine, I will also explain the essential shingles vaccine and exploring the relationship between shingles and old age. Please keep in your mind, from the previous presentation, one of the most important terminology about the immunosense that highlighted by our colleague, Dr. Muhammad, and also the vaccine, area also highlighted by our colleague, Dr. Afrah. So because I'm going to highlight more in depth, and go into details by taking an example of of this very serious infection known as, herpes zoster infection. This is my disclaimer. So if we go just, in the story of just to know more about the story of shingles reactivation with increasing age, so we have to put in our mind the three stages, actually reflecting the mechanism of the zoster infection. So, as you can see in this, illustration, more than 90% of adults, their age 50 and above, they are actually infected with varicella zoster virus and are at risk to develop the herpes zoster infection. And we mean by we know that varicella zoster virus is known as the chickenpox infection. So in early stage, as you can see in the left part of the illustration, that the varicella, when affected or in the early childhood, so as some extent or a control of the primary infection will occur due to the immune response. And in latency stage, this is in stage 2, the varicella zoster virus actually latent in a dorsal root ganglia will be actually at that site of the neuron. And in the third stage, and after the reduction of the immune control, and this is actually happening as mentioned by immunosense when the increasing the age, the immunity will be reduced, and this is a very high chance to the herpes zoster infection will occur. So in some statistics, the incidence rate of this infection, actually overall rate, it is between 6 to 8 cases per 1,000 person year at age of 60. And if you just go also into deep, or in some, other statistics, we will see also in United States, almost the estimated of 1 million new cases of herpes zoster infection. And in Europe, which there is, some kind of old ages, it looks like more people infected with, annually. It reached around 1.7 million in Europe, and in China around 1.5 million, cases annually. If you go also, into deep, exploring the burden of shingles, and also this burden of shingles or herpes zoster infection, actually it is increases with age, as I mentioned, and with a sharp increase from the age of 50 and above. And as you can see in this diagram, in this diagram also, there's actually some countries involved in this study. Exploring the incidence of herpes zoster, stratified by age in United States, in Australia, in Germany, France, Italy, and also in UK. And you can see the relationship between the incidence per 100,000 person per year and the age. You can see in this diagram, the infection is actually started sharply in the diagram at the age of 50. If you can just follow the diagram, you will see there is a sharp increase in the infection at the age of 50 with the decrease of the immunity around this age. So the percentage of herpes zoster cases followed by also there is some complication occurred due to this serious infection. And one of these serious complication, as mentioned by my colleagues, there is what is called the PHN, which is known as post-herpetic neuralgia. And as you can see in the right side of the diagram, this kind of complication, post-herpetic neuralgia, it is actually the proportion is double in the age of 70 and more. And you can see also even the increase with age and reach the high actually rate or percentage reaching even the people more than 8 years. So in conclusion to this slide, the incidence of herpes zoster and consequently post-herpetic neuralgia are expected to rise due to the aging population and the development of immunocompromising condition associated with aging. So how about the age-related decline immunity? As you can see here also in this diagram, the relationship between the cellular immunity induced by the infection of the chickenpox and and the age. And also you can see in the and the shingles threshold. This is a theoretical frame. So if you follow this diagram, you can see in the early age of life or during the childhood, where the primary infection induce specific cellular immunity. This immunity, it will be maintained for a while, and exactly there is a sharp decline at the age of 50, as you can see here. So varicella zoster virus specific cellular immunity will decline with age, and this sharp decline it is actually published at the age of 50. So the decline in cellular immunity, it is actually associated with an increased risk of shingles infection. So in statistics, one in every 3 people will get shingles in their lifetime. So the shingles risk increase with age, and with an increase beginning from the age of 50. And also, again, as you can see in this bar chart, the red color actually reflecting the incidence per 100,000 per 1,000 person year, and those they're immunocompetent, not immunodeficiency. With immunocompetent, also the over 90% of the people, their age 50 years and above, they will carry the virus that causes shingles. So how about the comorbidities and the risk to get the herpes zoster infection? So on top of age, a variety of other factors, apart from the age, also the further can elevate the patient's risk of shingles. And you can see here, for example, the diabetic patient, the risk increase almost reaching 30% of getting the infection, and reaching also in renal diseases cases like 29%, and with cardiovascular disease like 34% increase the risk of getting the herpes zoster infection, and also the other comorbidities. So how about the impact of this infection? A painful condition that disrupts quality of life. This is known as post-herpetic neuralgia. And let us go in deep and to know how about this kind of infection. Introduction to herpes zoster, in incidence is predicted to increase, presenting a gross burden in patient with comorbidities, as I mentioned, with diabetic patient, with cardiovascular patient, with the other chronic, illnesses. So herpes zoster is caused by reactivation of the varicella zoster virus, and this is happening, as I mentioned in the previous slide, with the increasing the age around 50 and above, and the varicella zoster virus in the latent in the neuron ganglia. And so age and immunocompromising conditions are well recognized to be a risk factor, and decreased varicella zoster virus specific cell mediated immunity, as with relationship with the age. So in people with this condition lead to varicella zoster virus reactivation. And one of these complications, as you can see in this picture, so herpes zoster is characterized by acute pain and a reduction in quality of life. And we will see in the next slides what kind of this, miserable quality of life, it affects many parts of, the patient lives. And as you can see here, it affects almost one of the complication, or the common complication, happened or occurred due to this severe infection. One of them in the left side, the ophthalmicus, the herpes zoster ophthalmicus, and this is almost accounted for almost 25% of the patient. And also the post-herpetic neuralgia is one of the severe complication. It actually reached almost like 30% of the patient. And another issue that is also, in the issue of the recurrence, it occurred in about reaching 10% of patients. They will actually, experience a recurrence of this, episodes. How about the course of the herpes zoster? The course of herpes zoster consists of prodromal, 4 stages, as you can see: prodromal phase, an acute phase, subacute phase, and post-herpetic neuralgia. In prodromal phase, this actually takes around 4 days and to extend up to 2 weeks, and associated with headache, photophobia, malaise, and fever. And for the acute phase, it would actually, takes around 2 to 4 weeks, and this is associated with unilateral vesicular rash and associated with acute pain. And for the subacute phase, this is up maybe take up to 3 months. And for the post-herpetic neuralgia, and as I mentioned, is defined as a neuropathic pain that persists for more than 90 days, and even it may be actually persist for many years. Comparison, if we would like to compare the pain that resulted from herpes zoster infection and the other diseases, you can see here in comparison between the acute and chronic, for acute infection like post-surgical pain and labor pain, we can, the shingles or the herpes zoster infection, is more actually associated with pain more than the post-surgical pain and labor pain. And for the chronic, condition like the chronic cancer pain and arthritis, still the post-herpetic neuralgia considers, the patient will suffer, with more pain than those, kind of chronic conditions. So comparison of a total, pain rating index is scored using a short form of MC-Gill pain questionnaire. This is, a selected condition from the original publication. And the conclusion for this slide: the pain resulted from the herpes zoster infection is actually very severe, and more, the patient will suffer more pain compared to the acute and chronic, infections. And so in pain from shingles and post-herpetic neuralgia can impact the quality of life, as I mentioned, of the patient life in different aspects. 97% of those patients actually they will have some kind of emotional functioning. 28% they will actually suffer from the cognitive function. 63% they will have some impairment of the social function. And as you can see, the work, career, and also the sleep and other part of the their lives, they will be affected definitely. So percentage of patients who reported impact of shingles on health related quality of life, as mentioned or as explored in this slide. So how about the herpes zoster and the comorbidity, or the patient with comorbidities? How about the presentation? We will take the first example, the diabetic patient, and this actually explored in two-way relationship. So actually the complication of diabetes itself, and also the diabetes will be a risk of infection of the herpes zoster. So the severity of shingles is increased in patients with diabetes mellitus, and accumulating evidence suggests that diabetes mellitus represent an important risk factor for post herpes zoster and post-herpetic neuralgia. And as you can see in the statistics, so 19% of the diabetic patient, they have an increased risk of getting post-herpetic neuralgia, and 63% of diabetic patients, they will have increased risk of herpes zoster related hospitalization, and also 18% of diabetic patients, they have increased risk of persistent pain known as post-herpetic neuralgia, and this is maybe persist for more than 6 months, which is considered a very long time suffering from this kind of severe pain. And in Saudi Arabia, 21.5% of herpes zoster cases are diabetic, and diabetes is the most common comorbidity of herpes zoster infection. And we know the incidence or the prevalence maybe of the diabetes in Saudi Arabia and some other countries maybe, reaching more than 25% of the total population. So, in also in other way, the diabetes, as you know, we have a two-way relationship. The severity of shingles is increased in patients with diabetes mellitus. As I mentioned, herpes zoster may contribute to a glycemic deterioration of diabetes. So both they are actually reacting in how to affect each other. So the diabetic patient infected with herpes zoster, we will notice that, or we will see the glycemic deterioration, and also the increased hospitalization also will occur. So 24% of individuals experienced an increase in hemoglobin A1C from below 6.5 to above 6.5, and this is known as uncontrolled kind of diabetes following an herpes zoster diagnosis. So herpes zoster infection will also make some kind of deterioration for the glycemic deterioration, and diabetes is an independent risk factor for post-herpetic neuralgia. Adult patient with cardiovascular. So we, in the previous slide, we have seen the relationship between the infection of herpes zoster and the diabetic patient. In the coming slide, we will also see what is the relationship between cardiovascular condition and the infection of herpes zoster. So adult patient with cardiovascular condition may be at increased risk of developing shingles in comparison with control group. And as you can see here, the shingles is also associated with an increased risk for cardiovascular condition. 78% of those patients with cardiovascular infection, with cardiovascular disease, if they get infected with herpes zoster, they will be at risk of hitting by stroke after 1 month of this infection. 25% of those cardiovascular patients, if they get infected with herpes zoster, maybe they will actually suffer from myocardial infection after 1 month of infection, and 22% of those patients will be at risk of arrhythmia within 2 weeks after the infection, and 14% of those patients will be at risk of coronary artery disease within 2 years of after the infection. So in summary, 34% of those cardiac or cardiovascular patient will they will be increased relative risk of developing shingles in patient actually with this different kind of complications. Is there any treatment for shingles? We will see in the coming slides if there is. I don't think there is a specific treatment for shingles, but and also we'll see if there is any limitation of the current treatment options. So herpes zoster related pain interferes with multiple aspects of quality of life, and as you can see here, during the rash of the onset of rash, so antiviral treatment can be given in acute herpes zoster infection, and antiviral can reduce herpes zoster severity and duration. Also, oral acyclovir dose does not reduce post-herpetic neuralgia incidence, and insufficient evidence for other antiviral treatment. So, for the cases of the post-herpetic neuralgia treatment, only 14% of patients with post-herpetic neuralgia are satisfied with treatment. So we can conclude that, and only 14% is actually very limited percentage. And so, what is the other option to control this kind of serious infection? So the Shingrix vaccine composition, as also, known as a boosting immunity against age-related decline. And the component of this vaccine, it has two components: the antigenic part, and this is known as a glycoprotein E, and this is considered around 50 microgram, and the adjuvant system, and this is considered of three parts: is MPL, QS21, and liposome. And the RZV vaccine, known as a recombinant subunit non-live vaccine. So it is a non-live attenuated vaccine. It is a recombinant subunit non-live vaccine. How was the efficacy of this vaccine? There is some trials actually implemented to measure the efficacy of this RZ vaccine. Let us see what is the efficacy data of this vaccine. So, two studies now here actually exploring the efficacy of this vaccine. And the first study, known as ZUI 50, and this is actually for the age groups of patients, their age of 50 and plus. And the second randomized control trial, known as ZUI 70. This is for age group 70 and above. And these two studies actually implemented in 18 countries. So the study design is known as randomized, observed, blind, placebo-controlled, multi-center, and multinational. As you can see in the map, 18 countries included in this study. And for the patient, their age 50 years and above, actually 16,160 included in this study, compared to almost like 50,000 patient their age 70 and above. And this study actually measures the efficacy against herpes zoster infection, and also against the post-herpetic neuralgia and other complications. In some details about these studies, so in terms of efficacy against the herpes zoster infection, and those as you can see, the efficacy is very high. And for example, for the ZUI 50, as you can see in the left side, for those age groups 50 and above, the efficacy reaching 97.2%, which is considered is very high. And for those in the same study, their age more than 70, the efficacy of this vaccine reaching 97.9%, compared to those other age groups, their age are 70 and above. As you can see, also still the efficacy is very high, as reaching 91% for those their age 70 and more. And also the efficacy is very high for those age group, their age 80 and above, reaching 91.4%. So the efficacy considered is very high. How about the follow-up for this efficacy? How many years this efficacy will remain as a high immunogenicity? As you can see here in this, the shingles protection lasts up to 11 years. And this actually, actually presented by another study known as Zoster 049, and for also for the ZUI 50 and 70. The conclusion up to 11 year, the efficacy remained very high, as 87.7% against herpes zoster infection, and also no new safety concern were identified in ZUI, the long-term follow-up, and year 6 in the year of 6 to up to the 11 years since the vaccination. How many doses we should give to the target groups to maintain or to induce a high immunogenicity? We need 2 doses, and please, this is one of the I want to concentrate in this slide. As a message to be taken home. 1 dose is not enough for those target groups, so we should actually focus as the healthcare professional to follow our clients for this type groups. So we should be aware and be careful. All those type groups, they should take 2 doses of RZ vaccine and if they, if you compare patient with one dose and the patient receiving two doses, actually patient receiving two doses, they are 4 times more, immune response than those actually taking, one dose. And in our system here in Saudi Arabia, we have a national immunization program recommended 2 doses. The interval between these, the first and second dose, it will actually 2 to 6 months. But I would like also to concentrate on this issue. Please, for your patient, as soon as possible, when you start giving the first dose, just encourage them to take the second dose as early as, at the interval of 2 months. And for those immunocompromised, as mentioned by our colleagues, the interval is not 2 months, is a little bit shorter. If you have immunocompromised patient, also they have to receive 2 doses, but the interval, it should be shorter. We should give them 1 dose, and the other dose is only after 1 month. How about the safety of this vaccine? According to the studies actually implemented to measure the safety of the vaccine, so most vaccination reaction were mild to moderate, and as you can see, the local reaction and also the general reaction, local reaction like pain, swelling, and redness, actually they are not huge number comparing to the general reaction. So no increase in serious adverse reaction, and this is published in or followed in patient in ZIWI 50 and 70, and also safety profile remained clinically acceptable up to 10 years post vaccination. So we can say that we can conclude the safety profile, the vaccine is very safe, and for the other issue, for the technical issue and administration, the RZ vaccine should be refrigerated in between the 2 and 8 degrees, and after reconstitution, as I mentioned, we have 2 vials. One when the vials of the powder and the other is adjuvant. So RZ vaccine is stable for 6 hours when kept in the refrigerator after the reconstitution. And as I mentioned, RZ vaccine is supplied in 2 vials for reconstitution, 1 vial for the antigen part, and the other for the reconstitution. And the RZV vaccine is for it is actually intramuscular injection. And the target groups, as I mentioned, we have 2 target groups: 50 years and above of age, and the other groups is 18 years and of age. And and those patients from 18 to and less than 50 should be associated with the risk factors. The contraindication, like the other vaccines, so patient with if they actually suffered from hypersensitivity reaction, they should not receive the second dose. And the RZ vaccine is not is not indicated for a prevention of primary varicella infection. And some of we have actually this issue raised by many of our colleagues in primary health care centers. We should be careful that the RZ vaccine is not indicated for to prevent the chickenpox. Chickenpox, as we know, it has actually a very specific vaccine. It is actually known as varicella vaccine. So the co-administration for is it possible to co-administer the herpes the RZV vaccine with other vaccine? Yes, and according to the other vaccination mentioned by our colleague Dr. Afrah. So the co-administration can be administered with influenza, with pneumococcal, both of BCV13 and PPSV23, and also with DTaP vaccine, and the co-administration generally well tolerated, and we can easily administer this vaccine in the same session, and no safety issue raised and no immunologic interference observed if we administer those vaccine with RZV vaccine. Regarding the guidelines and recommendation in Saudi Arabia, we have our we have a recommendation. So the CDC recommendation, and yeah,
2 minutes.
okay. CDC recommendation vaccination against shingles is, actually for those patients 50 years and above, and also for the patient 18 and less than 50, and also the other, countries are actually they have their own recommendation, like in United States, Europe, and Australia. And vaccination against shingles is recommended for the high risk groups, as I mentioned: diabetic patient, cardiovascular, asthmatic patient, and COPD patient. And by this slide, I finish my presentation. Thank you for for listening, and get back to you, Dr. Raja.
Thank you, Dr. Dafalla, for this excellent, insightful presentation. You clearly highlighted that shingles is not just a benign condition, but a significant and often under-recognized, particularly among adult and high-risk population. Your talk was reinforced the importance of early prevention and the role of vaccine in reducing complication and improving quality of life. And this is a strong reminder that prevention remains the core of effective healthcare. And today's discussion highlight a critical message, very important message, that we need to take the opportunity to ask any patient visit our institute that they should get their vaccine. And what really faces not a knowledge gap, it's an implementation gap. And the solution is making the vaccine within the routine care. Now it's the floor for question. We have several questions for our distinguished speaker. First question is about what about live vaccine in children? Are they safe and when are they recommended?
Can I answer, please, Dr.
Yes,
Raja?
yes, Doctor, yes.
Yeah. If I understood the question is they are actually asking about the administration of live attenuated vaccine among childhood. Is a question like that?
Yes, yes.
Yes, yeah. You know that we in Kingdom of Saudi Arabia, and also in other parts of the world, we have a certain life attenuated vaccine administered for a certain target groups. For pediatrics, we have the previously before 2019, we gave the PCG vaccine at birth, and now shifted to be given at 6 months. This is for our schedule here in Saudi Arabia, and it is actually given for all children their age between 6 months and 1 year. Also, we have the oral polio vaccine, and this is one of the life attenuated vaccine given to pediatrics. And also we have the MMR vaccine, the measles vaccine, and varicella vaccine. All these are included in the Saudi Arabia routine vaccination schedule, and given with certain precaution. We have to put in our mind that there is some contraindication for life attenuated vaccine. For those, for example, if you have children with immunocompromised children, life attenuated vaccine is contraindicated. And some of them, if you have children have received like, for example, an MMR vaccine, blood transfusion, or they have some kind of antibiotic sensitivity. So we have to consider in a very small and rare groups, we have to put in our mind that we should take into consideration the contraindication of this life attenuated vaccine. Thank you.
Thank you. Thank you, Dr. Tafalla. There is here a question. Is there any difference in the risk for development shingles between those who have chickenpox infection and those who have the vaccine during childhood?
Yes, I presented in my presentation, the more than 90%, as I mentioned, of infected people with varicella zoster virus will be at risk, to reactivate this, virus the latency and in the root, in the dorsal root ganglia, and they will be at high risk to reactivate this infection, and especially those patients at age increase the risk at age of 50 and above, and also those patients between 18 and less than 50 with with some chronic condition. So the risk is very high if those actually get infected with varicella virus.
Doctor, are you aware about any research compare the two group? Those who
No, no.
vaccine?
At this moment, I don't know any. I cannot remember any statistics regarding this.
Okay, thank you. Type. And next question, what are the key vaccines every adult should not miss?
I can take this question.
Okay.
So every adult, the minimum, which we encourage you to think about, is influenza vaccine every respiratory season to protect you, your children. And again, we have seen we've seen the power of the vaccine in the years when the vaccine did not protect. So just to give you a story, when I was a resident, we had 1 year where the vaccine did not capture the circulating strain. I remember the hallway of the hospital had patients stretchers on the hallway because we could not find enough beds. We had young patients as young as 18 in the ICU because the vaccine failed to capture the strain. So this is the story to tell you how powerful these vaccines are when they work at protecting. So influenza is a point of no compromise. Again, the other things, as people get older in age, we encourage the pneumococcal vaccine, especially with comorbidities. Anybody, hypertension, chronic kidney disease, chronic liver disease, almost all our patients are candidates for the pneumococcal vaccine. So those are the two I always keep at my available at time of discharge, and those are easy. They don't have a lot of side effects. It's just one poke. They're compatible, can be given together. So those are the first two I focus on. The third I obsess over is the zoster vaccine. And again, it's a bit more difficult since people have some pain at the injection site. But those are the three top vaccines I really, really push aggressively with my inpatients and outpatients. Again, taking their comorbidities, there's, as I mentioned in the talk, certain populations based on their biologic, based on their medications, based on are they on dialysis or not, they may need higher doses of other vaccines. But the top three, as a blanket recommendation for everybody, those would be my favorite choices. But again, I'll open the floor to my colleagues. They may have their favorites.
Thank you, Doctora. There is another question. If Shingrix vaccine received more than 2 doses, does this have any concern?
Thank you, Dr. Raja. I think this, very rarely happen. But if it is actually, administered in, we call this is as, in a programmatic error. If received more than, it should not, actually, according to the recommendation, the tag group should only receive 2 doses. But, there is no any actually data reflecting if there is some kind of reaction will occur if the patient received more than 2 doses. But in reality, in terms of programmatic error, this is occurred. But I don't have any kind of published data, to reflect if there is any adverse reaction or any issue like that. But generally, in terms of administrating the killed vaccine, as you can see, if we compare generally, the recommendation for example, we have a booster dose of some vaccine. Actually, it can be given in interval, like meningococcal conjugate vaccine can be given every 5 years, and also the Tdap vaccine also can be given in a certain way. So we don't have any data reflecting if patient receive more than 2 doses. But if we just applied the issue of kill vaccine, I don't think the patient will develop any kind of serious adverse reaction. It may induce more, actually kind of it will be like a booster dose.
Yes, thank you, Doctor. I think this is related question and maybe strongly related to the previous one. The question is regarding herpes zoster vaccine. What if I forget to take the second dose of herpes zoster after 6 months?
Yeah,
I
this
think
is
the
very
question,
common.
do they need to repeat the 2 doses? I think,
Yeah,
yes.
no, this is very common question. According to the to data available, and this is very common question raised from the many areas. As I know, it is up to 2 years. If the for example, we'll give an example for that. If we have a patient receive one dose, for example, at the beginning of this year, and the second year, I mean after 1 year, he came, we should not start from zero. We should give immediately the second dose, and this should be counted up to 2 years. After 2 years, I don't know if we should start from zero or no. But up to 2 years, we can give the second dose. No need to start from zero.
Mhm. Okay, thank you. Here question about medical student and healthcare workers at risk for infection. What type of vaccine recommended for them?
So I can take this one since I addressed this in my talk.
Yeah. Mhm.
So again, healthcare workers are on the front lines, and they're the ones we always want to protect. So again, we always, as part of influenza, as I mentioned, is important. Hepatitis B, because again, as a healthcare worker, you're at risk for needle stick injuries, which may not happen anywhere else. Mumps, measles, rubella, you may or may not need a booster. So again, some centers they check your immunization history. Some centers they check your antibodies, even though it's not recommended. So a mumps, measles, rubella booster is not unreasonable. And pertussis, as I mentioned, you need a Tdap, and you want to take at least one dose with the pertussis. So rather than doing just TD, which is just the tetanus and diphtheria, you want one dose with the pertussis component because again, if anyone's going to get exposed to it, it's going to be you as a healthcare worker.
Mhm. Thank you, Doctor. I think because we are now at the time of Hajj, one question about meningococcal vaccine for pregnant women going to Hajj, the recommendation.
So meningococcal is not a live vaccine, which makes it, a good vaccine to use. So again, at least 2 weeks prior. It's not routinely. So again, there's no clear contraindication or reasons not to, and the protection will be higher than any harm. So again, I would encourage if you can do 4 weeks prior to Hajj would be great, but minimum 2 weeks to build some antibody response. Because even pregnancy is kind of an immunocompromising state. So again, the antibodies they may build during pregnancy may not be as robust. So the more time you have, the better, I would say.
Mhm. Thank you, Doctor. I think we have more question, but not related to our talk today about co-administration of of meningococcal vaccine, influenza, and pneumococcal together.
Sorry, which three? Influenza, pneumococcal, and?
Meningococcal.
Yeah, the influenza and pneumococcal, I'm sure about. They have been given together. As for meningococcal, I believe it's part of the Hajj vaccine protocol. So I don't think there's any clear contraindications.
Okay, thank you. Now, I think for the sake of time, we are about to reach to the end. We want to conclude now. If you have any recommendation or anything to say for our audience, Dr. Muhammad, Dr. Dafallah, Dr. Afrah.
Yes. So this is one thing I feel a lot of clinicians struggle with. And I've seen one or two questions in the group about the chickenpox vaccine and the shingles vaccine. So in the normal population, we don't check. We don't check for antibodies. We go directly to the shingles vaccine. This is the immunocompetent. If I take my mother, you take your parents, they are not going to go and check them. So you go straight for the shingles vaccine. In the immunocompromised, in the transplant patients, we have only one opportunity, right? So that population, we take the antibodies, we give them the varicella vaccine first, and then the shingles vaccine a second priority. Okay, so that's the only population where the varicella vaccine is given more importance because it's live, and that's your only opportunity. But for everybody, adult in the community who are, not getting a transplant, we go directly to the shingles vaccine.
Thank you, Dr. Afrah. And as we come to the end of this session, I would like to thank our distinguished speaker for their insightful contribution and our audience for their active engagement. And today's discussion highlighted the critical message: vaccination is not just a childhood intervention, but a lifelong strategy that protects individuals and population. And the real challenge is no longer evidence, it's implementation issue. As a healthcare professional, we have the opportunity to turn every patient encounter into a moment of prevention. Vaccines do not only save, they shape healthier future and entire population. And thank you for all of you and wishing you a meaningful immunization week. And thank you very much.
Thank you very
Thank
much.
you.
Yeah.